بسم الله الرحمن الرحيم. مؤنس أكاديمي قدم هذا العمل خالص لوجه الله الكريم، آمل أن يكون عونا لشباب الأطباء يقدموا خدمة صحية عالية المستوى ترقى بمكانة الطبيب العربي وتخدم المجتمع بأمانة وإخلاص. Episode number 5. From bedside to the best practice. Here's a case of 33 years old man coming with attacks of bleeding per rectum. It's 3 attacks in the last 5 months. He have no history of bowel habit changes, non-steroidal anti-inflammatory drug, or any significant prior medical or family history. His CBC is normal. You decided to do a colonoscopy, and while you on colonoscopy you found this polyp in the ascending colon. Narrowband image showing this picture. You endoscopically remove this polyp with a hot snare, then send it for histopathology, and histopathology coming back with this picture. So according to your diagnosis for the type of the polyp, you will recommend him to come back in 6 months, or in 1 year, or in 3 years, or you will send it him for genetic mutation to know what is the germ type, and or you will say to the patient that you are cured, you don't have to come back for follow-up. What's your answer? Yes, no need for more follow-up. Why? Because I diagnosed this patient as a juvenile polyp. Juvenile polyp has a characteristic histological appearance, which is cyst architecture. This cyst is filled with mucus, prominent lamina propria, dense infiltration of inflammatory cells. Most commonly occur in childhood, typically occurred in patients less than 10 years. Diagnosis is done at the adulthood after episode of bleeding. The juvenile polyp is sporadic, not associated with juvenile bulbosa syndrome. Non-neoplastic. If completely removed, no need for more surveillance. عشان نحفظ الهيستولوجي بتاع juvenile polyp نفتكر كلمة اسمها جوس. J for juvenile, it's hamartomatous, it is non-neoplastic. U, ulcerated surface. I, inflammatory stroma, edematous lamina propria with inflammatory cells. C, cystic, dilated gland filled with mucus, and this is a characteristic of juvenile polyp. E, edema anywhere. Loose, extended lamina propria, separated glands. Case number 2. 28 years old man with a previous medical history, with no previous medical history. He coming with symptoms of mild fatigue, and 3 weeks previous he will go and running 10 kilometer in a race. On physical examination, lung is clear, liver 10 centimeter below the costal margin, smooth surface, no skin lesion. Lab evaluation, the hematocrit at 26, mean corpuscle volume is low, serum iron is low. So you have to decide it to form a colonoscopy. While you are on colonoscopy, you notice more than 75 polyp through all over the colon. Most of them less than 5 millimeter. 10 was pedangulated to polyp about 2 centimeter. You remove all the large polyps with a hot snare. So decided to do an OGD in the same session to exclude any more polyps in the stomach or in the proximal jejunum. the pathology come back saying it is a juvenile polyp. So what's your diagnosis? Is it Cowden syndrome, or it's Pitt-Jagger syndrome, or it's M mutant associated polyp, or it is a hemorrhagic hereditary hemorrhagic telangiectasia? Please answer. Yes, it's Pitt-Jagger syndrome. Why? Hematomatous bullosa syndrome. This patient has a dominant multiple colonic juvenile polyp, indicated that the patient has hematomatous bullosa syndrome, not adenomatous bullosa syndrome, such as MUH associated polyp. This patient has a juvenile bullosa syndrome with hereditary hemorrhagic telangiectasia overlap due to the finding of multiple colonic polyps, and liver is bright. Both conditions are usually a germ detected with SAMAD germ. Arteriovenous malformation can be found in the overlap syndrome in lung, brain, liver, and another organs. There is three major hematomatous bullosa syndrome: juvenile bullosa syndrome, Pitt-Jagger syndrome, P10 hematomatous tumor syndrome. Juvenile bullosa syndrome has a by MBR A1 by MR or SAMAD germ. It is an autosomal dominant hematomatous polyp. 50% has a risk of GIT cancer and occur in 30s, so early in life. Most common site in the colon, duodenum, stomach, or pancreas. Germ mutation, which is the DIMB R1A or SAMAD 4, is identified in 60% of patients. Surveillance colonoscopy should be performed every 3 years from the start of the symptoms, or in 10 years for asymptomatic patient with positive family history. OGD should be performed 2 years beginning after the age of 15. Juvenile bullosa syndrome criteria when you suspect juvenile bullosa syndrome: if you found more than 5 juvenile polyps in the colon, or you have multiple juvenile polyps through all over the GIT, or patient with family history of juvenile bullosa syndrome plus any number of polyps. This is diagnosed as juvenile bullosa syndrome. If you send it and you found it's SAMAD germ, so this patient will have overlap between juvenile bullosa syndrome and hereditary hemorrhagic telangiectasia with telangiectasia epistaxis and AV malformation, and aortopathy associated with aortic dilatation. The histology of juvenile bullosa syndrome is as same as juvenile polyp, except the edema feature which is present in juvenile bullosa syndrome. Second is the Pitt-Jagger syndrome. Pitt-Jagger syndrome genetic, it's autosomal dominant, related to STK11 mutation. Feature is have to combined with mucocutaneous pigmentation, mostly in the lips, mucous membrane, and fingers, with polyps mostly in the small bowel, and mostly patient will facing intussusception because of these polyps. These patients have a high risk of cancer in the GIT and in the breast and testes, or ovary, cervical, and uterus. Her overall life cancer risk is more than 90%. P10 hamartomatous tumor syndrome, including 3 types or 3 syndromes. Cowden, which is the most common, Rotor syndrome, and Banani syndrome. The germ is B10. Cancer risk in breast is 85%, thyroid 35%, endometrium is 28%, and colon 16%. Picture of the Cowden syndrome نحفظها بكلمة hamartoma. H is hamartoma or polyps in the GIT. A, acral keratosis, macrocephaly. Adenocarcinoma for breast والendometrium. R for renal cancer. T for trichomonas. O for oral papillomas. M for melanoma, and P10 is a pathway. In conclusion, juvenile bulbosus syndrome is a cystic dilated gland, mucus leak, and inflammatory stroma. Pitt-Jagger syndrome, branching, smooth muscle extended into the polyp. Even Cowden syndrome mixed between mesenchymal and epithelial element. The take-home message: when you found polyp, you have to put it in what is the polyp. It is adenomatous polyp, or juvenile polyp, or Pitt-Jagger syndrome, or juvenile bulbosus syndrome. To know the treatment and know the incidence of and know the way for surveillance. Thank you.